Hello everyone, welcome to Diagnostic. So now let's discuss our new case. So a child is presented with the following symptoms, that is the periodontitis, ulcers without the pus formation, and there is a history of recurrent bacterial infections. So as in the image we can see this presence of these ulcers without the pus formation. And what is this periodontitis? So periodontitis is a serious gum infection that can damage gums and also can destroy the jaw bones. So based on these findings, we can say that it is a case of leukocyte adhesion defect. More specifically talking, it is the lead one. So now in the later part of the video, we'll discuss about different types of leads. So it is a lead one. So what are these leads? So these are the immunodeficiency disorders which involve both the B and T cells, and these are characterized by the inability of leukocytes to migrate to the site of infection to kill the offending microbes. What is these? These are the immunodeficiency disorders. Immunodeficiency disorders. They involve both the B cells and the T cells. And these are typically characterized by the inability of leukocytes to migrate to site of infection to kill the offending microbes. Lead is a defect of cellular adhesion molecules resulting in clinical syndromes. And the major immunological features which can be found in these are there is inability to form the pus, inability to form pus. There will be deficiency of the glycoproteins, deficiency of glycoproteins. There will be abnormal inflammatory responses, abnormal inflammatory response shown by the body, and the other one can be due to decreased immunity or the immune response. There will be recurrent chances of the bacterial infections. So this was the basic general introduction of leukocyte adhesion defect. So now let's discuss further. Talking about the types of lead. So basically we have three types of leads. That is the lead 1, lead 2, and lead 3. So now in the lead 1, there occurs a mutation in the CD18 gene, due to which what happens, there is a defective or deficient beta-2 integrin formation. So what happens in the lead 1? In lead 1, there occurs a mutation in the CD18 gene, due to which there occurs either the defective formation of beta-2 integrins or there is deficient or decreased formation of beta-2 integrins. Now, in what happens in the lead 2? In the lead 2, there occurs the absence of silyl Lewis X, which is of E-selectin. So SLX deficiency occurs in the lead 2. What happens in the lead 3? So lead 3 is a defect in beta integrin 1, 2 and 3, due to which the integrin activation cascade is specifically impaired, and hence it occurs basically due to the mutation in the kindlin 3 gene, due to which there occurs the defect in the, as I also told, beta integrin 1, 2 and 3, and then which leads to the impaired integrin activation cascade specifically. So these are about the types of lead. And when we do a biopsy of the infected tissue, then it also demonstrates a inflammatory infiltrate which are completely devoid of the neutrophils. So at the site of the inflammation or the infection, in the inflammatory response, we doesn't see the presence of neutrophils, due to which there occurs the absence of the pus formation. Now let's talk about the patient presentation part, that is how a patient of leukocyte adhesion defect is presented. So the classical presentation of lead is the patient presents with history of recurrent infections, and along with this there occurs the umbilical cord slowing delays. There is delay in the slowing of the umbilical cord. Umbilical cord slowing is delayed. Also the defect in adhesion, it leads to the pure leukocyte chemotaxis. Chemotaxis of leukocyte is impaired, and hence it leads to particularly the chemotaxis of the neutrophils is impaired, and hence it leads to the inability to form the pus. Now talking about the specific presentations in each type of leukocyte adhesion defect. So first of all, let's discuss about lead 1. So in lead 1, the patient presents with delayed separation of the umbilical cord. There are history of recurrent pyogenic infection history, and the onset of the infection occurs in the first few weeks of the life. there is absence of pus formation, and also there are history of periodontitis. So these are the same histories which are presented with our initial case, which is there in the post. So in the lead 2, what are the presentation? So in lead 2, there are recurrent skin infections. There are recurrent skin infections. There can be history of pneumonia, TB, and the infections which occur in the lead 2 are less severe as compared to the lead 1. There are less severe infections. And now talking about the lead 3. So in the lead 3, the histories can be of omphalitis, osteoporosis. There is bone marrow failures or the depression of the function of the bone marrow, and also some bleeding complications are also found in lead 3. So this was the patient presentation part of leukocyte adhesion defect. Now discussing about the diagnosis part. So the first test that we have is the flow cytometric analysis. In this test, we demonstrate for the absence of the functional CD18 gene, and also for the absence of SLX molecule. In the second one, the second test is the quantitative serum immunoglobulins, in which we see for the presence of these or the amount of these antibodies, that is the serum immunoglobulins, that is the GAME. Third one is the antibody activities, in which we see for the activity of various antibodies, for example of IgG. The fourth one is the blood lymphocyte subpopulation, in which we see for the total lymphocyte count and also for the separate T and B lymphocyte. The fifth one is the complement system evaluation. We can carry out an evaluation for how the complement system is working. Other tests can be, we can have the phagocytic function test, phagocyte function test. These can be the NBT test and the neutrophil. We can also measure the neutrophilic mobility. NBT stands for the nitroblue tetrazolium. So what comes under the phagocyte function test is the NBT and the neutrophilic mobility. And the last one we can do what is the lymphocyte stimulation assay. So out of all these tests, the flow cytometric analysis is the definitive test. It is a definitive test. So this was all about the diagnosis part. Now let's discuss about the treatment part. So in the treatment of the lead 1, we can offer the patient with the allogenic hematopoietic stem cell transplant, also known as the HSCT. In the cases of the mild lead 1, the use of ustekinumab, this compound, it is what is it? It is a monoclonal antibody. Which is successfully used to treat the refractive periodontitis and the ulcers. Other therapies which we can use is, we can use the recombinant human interferon gamma. A trial of fucose supplementation is also recommended for the treatment of lead 2. Fucose supplement. For the lead 2. And the recombinant factor 7A administration is quite effective in treating the severity of the bleeding. So this was all about the treatment part and also about the leukocyte adhesion defect. So thanks for watching. Don't forget to like, subscribe and share Diagnose It, and also do follow us on Instagram. So thank you.